go, and later in the discussion we will try to give you an overview how to read a guideline and how to make our own notes. Okay, so of course, there is plenty of help available here and there, but that is not going to help you unless you are going to be uh, you know um, very good in and thorough in your own study. Very low voice, I think. If I'll go more than that, so my neighbors will listen to this session. So am I audible, everyone, or is it some problem?
Yes, we can hear
It's
you.
okay, madam.
Okay, that's fine. That's fine. Okay. Thank you, thank you. Okay, fine. So we are going to start with this thing that MRCOG part 2, and everybody says that it is a tough exam, and I mean, indeed, it is one of the toughest exam because you have to cover a lot. You have to do a lot of, you have to cover a lot of syllabus in terms of that. We have got plenty of guidelines. We have got talk articles to read, and we have got, so many things to cover from. So what you have to do is that, of course, you have to make a schedule in a way that, I mean, it should be applicable. It should be, adjustable according to your, the hospital routine. Of course, almost every one of us is working, and some of us are the mothers as well. So I mean, it looks at times very difficult that this is not going to happen. Okay, but of course the smart study and the perfect guidance can lead you to sail through this exam in a very good way. Okay, so we are trying to help you in this thing that how you can make your own notes and how you can take help from us as well in terms of the course. So I mean, it is not like, I mean, 100% that you have to take courses. We are running so many free groups, and we are trying to guide on daily basis to everyone, okay, from part 1 to part 3. Okay, so it's not like that, I mean, this is, I mean, solely is going to be that, I mean, you have to just study in this case. Okay, you can listen directly as well, Papa Ki Pari. um, I think you can listen to it, and you can use your hands free as well, whatever suits you. Okay, anyway, so I'm Dr. Zaib Qureshi, and many of you guys know me, and we have Mohammed Hasan, our teacher, and most, I can say the very experienced mentor in mentoring this part 2 and part 3. And yes, we have our very enthusiastic and very, the energetic, our mentor, that is Dr. Pradnya. So we are going to, trying to give you an overview that how this exam can be like, I mean, easy. So let me just show you one thing before we start our session, because if many of you guys have seen this picture, so do you guys know what exactly it is? Anybody has any idea? This is the, I
Royal
mean,
College.
yes, this is the
Royal
old
College.
Royal College building. And this used to be a dream for every MRCOG candidate to stand here and to take a picture. And I'm sure you must have seen the many pictures around where the many the candidates, they stand over here and they do take pictures. And trust me, this really gives a kind of motivation that okay, you will go to your convocation and you will see this building with your own eyes, and you will have the kind of a picture over here. And make it a kind of the start, and just try to imagine yourself that you are going to stand over here. But recently, this RCOG building, I mean, last year, I think it has been moved to the, this Union Street building. And this is also very beautiful, isn't it? But personally, I think this was, the kind of, the dream of every MRCOG aspirant to go there, to have, the picture over here when they go for the convocation. Okay. But moreover, we can have this building in our mind that okay, one day I will clear my MRCOG, I will go there in convocation ceremony, and if everything goes fine, keeping in view of the current COVID pandemic. So of course, everybody has a the kind of dream, and it's a right to go there and to have the picture in this the kind of a very beautiful building. Okay, so this is a new building of Union Street, London, and the same RCOG new college, and this is also very beautiful. So I could not bring the many of the pictures, but of course I would have brought many pictures from there. So you guys can, just go to the RCOG website and you can see yourself, but, keep it in your mind that, reaching at this building, standing in front of this building should be, the kind of a very good, I think, happening in every student's life, because we are in this MRCOG journey. So of course, we should be doing our, the utmost, the preparation and utmost best to reach that level. Okay. So I know, inshallah, inshallah, Tavinda. So before, starting this preparation, what you have to tell to yourself, you have to give a reminder to yourself that, today is a new day and it brings with it a new set of opportunities for me to act on. I'm attentive to the opportunities and I seize them as they arise. I have full confidence in myself and my abilities. Look, this thing is very important. You have to be confident enough in yourself. Okay, you can study very well. You can sail through this, the journey. Okay, nonetheless, this is a very difficult one. But if I can do it, if Pradnya can do it, if any of the MRCOG candidates then can do it, then certainly you can also do it, isn't it? So just be confident. So I mean, give this reminder to yourself on a daily basis that okay, I have to do it. Okay, I know myself and I know my abilities and capabilities as well. I can do all things that I commit myself to. There is no obstacle which is too big and too difficult for me to handle, because what lies inside me is greater than what lies ahead of me. Correct, isn't it? So you should be thinking this way that okay, I am going to start my part two journey. So I'm not going to, let myself down in a way that I can't do this, I can't do this. I know curriculum is so huge. I know there are so many things to cover. But the problem is that, if you don't, build yourself, if you don't make yourself confident for this journey, so, this is not going to happen for you. Okay. So, you should be reminding yourself that I am committed to improving myself and I am getting better daily. And I think this should be the approach as a doctor for all of us, because we all are, the kind of excelling in our careers, because we are aiming for the prestigious degree that is MRCOG, isn't it? So you should be thinking at all times that I have to improve on myself. I have to get better daily. When I will get guidelines, so I will be thinking, okay, when I will be in hospital, so what I'll be going to do, where I'm going to apply that guideline, isn't it? So you have to, reminding this thing yourself to daily basis. Plus, I am not held back by regret or mistakes from the past. You don't have to say that at all. I am moving forward daily. Remind it. Okay. Give yourself a strong reminder. And absolutely nothing is impossible for me. This should be the spirit for every, the new thing when you are going to start. Okay, for this MRCOG2 journey where everyone says that this is very tough, this is very hard, and this and that, there is no doubt about it that it is a tough journey. But what you have to do is that you can just tell it to yourself that absolutely nothing is impossible for me. I have to move on, I have to study, and that's it. Okay, so you just have to give this reminder. So I just thought to give you this the kind of motivation before starting this journey. So I hope this is going to help you guys. I can see Sir Hassan is here. Hello, Sir Hassan. Sir Hassan is like our most the kind of senior and experienced mentor in MRCOG. Hello, good evening, sir.
Good evening.
How are you? I can't hear you, Dr. Hassan. So today we are going to discuss, what exactly the curriculum of MRCOG Part 2 is, how to prepare for it, what are the general strategies to prepare, and then, later in this discussion, we will be talking about how we are going to help you in terms of, the dedicated schedule and the study, and that is going to be the course. Okay. So in terms of curriculum, again, everybody will say that this is so huge. Yes, it is huge, because we have got the plenty of modules to cover, isn't it? So we have to cover clinical skills module. Okay, we have to cover teaching and appraisal and assessment. We have to cover information technology, clinical governance and research, core surgical skills, post-operative care, surgical procedures, antenatal care and maternal medicine, and this makes this, the journey very tough, because these two modules comprises almost 50% of the curriculum. Okay, so if you are not that good in covering these two modules, so I mean, yes, that is going to make your journey, the difficult in terms of, because there are so many talk articles, there are so many green top guidelines and nice guidelines as well. Okay, I will be telling you, and the upcoming slides, that how, I mean, the maternal medicine and antenatal care overlap and how we have to cover them up. Then of course we have got management of labor, delivery, postpartum problem, and sometimes it comes as a whole. Okay, labor, delivery, and postpartum. Gynecological problems like, I mean, HMB, PMS, vaginismus, and etc. etc. The benign gynecological disorders. Subfertility, very important. Sexual and reproductive health, very important one. Early pregnancy care, gynecological oncology, urogynecology, and pelvic floor problems. So of course, we do have almost, as a whole, we can say that we have got 18 modules to cover from. But of course, then these, the 4 modules, these, of course, we have to learn about, the basic aspects of these modules. But, you can't cover them from, the good source. We have got, the clinical governance and research, we have to cover from strategy e-learning. For or information technology, we have to cover it, I mean, from strategy e-learning, teaching, appraisal, and assessment, of course we have to study, and then clinical skills as well. All right, then core surgical skills, post-operative care, surgical procedures, antenatal care, maternal medicine, we do have plenty of guidelines and talk articles available for them. Okay, so management of labor, delivery, postpartum, this is a very beautiful and very, the good module. People who are very much interested in practicing obstetrics solely, so they show, I mean, a very good interest, and they do cover this module very beautifully. Because, once you are applying all these guidelines in your day-to-day hospitals, so of course, this is going to give you a clear idea. But another question many candidates ask that, okay, we haven't done any training, or we don't have any kind of, the good hospital, the kind of, what you can say, the exposure. So it doesn't matter. At least you are a doctor, you know how labor ward, where exactly the labor ward is, and how OBG exists in this, the whole, the kind of the medical career, isn't it? So at least you guys can have idea. You guys can go through, many things. We have got, a lot of help available, here and there. So you guys can always go through the questions, and then, you guys can ask, and then there is going to be CTG as well, cardiotocograph. So of course, I mean, that is the essence of labor delivery. So yes, you have to be good in that. So like I said, that the people who are solely practicing obstetrics, or they are having, the more interest, so they do very well in this module. But it doesn't mean that the people who are not working in hospital, or they are straight, jumping from part 1 to part 2, because these days there is no, the kind of assessment of training, and we don't need any kind of training for part 2. So of course, many candidates do find it a bit difficult. But I must say that if you have, the background knowledge, and if you have, the solid concept that how things works, so I think you can do very well in all these modules. Okay. So for, the gynecological problems, I would like Dr. Hasan to comment on these, the modules, how to prepare and how to go about these modules. Dr. Hasan, are you
Yes,
there?
Dr. Zaib.
Yes.
Thank you so much for explaining the obstetrics
Yes, thank you.
modules. It was magnificent, by the way. Now, regarding the gynecology modules, um, most of people are working a lot in obstetrics, okay? But the subspecialties are subspecialties. So they are somehow difficult to be fit in all these subspecialties. For myself, for example, oncology and urogynecology are my subspecialties. So I understand them very well. I know the basics, so I'm fit in them. Now, subfertility, I know the basics, but this is not my subspecialty. So how can I manipulate gynecological modules as professional personnel for exam? Now, we have nothing to do rather than understanding very well the proper source to study from for each module, and to be very, very sticky to the guidelines. Don't try to put your touch, okay? You know, I know many people, they are trying to study a lot of sources. Let me give you an example. In subfertility, as an example, subfertility, we have multiple sources to study from. TOG articles, maybe more recent than the NICE guideline 156, number 156, 2013. Sometimes you may find scientific impact papers related to subfertility because it's a very improving and hopeful branch. So every day you will find another source to study from. Now, recently, you will find multiple sources from ISHRI, for example. What should I follow? Okay. Now, for example, in infertility, I should follow the NICE guideline, even it's older one and old version, but this is the recommended approved source for the exam. So if you find, for example, any conflict between the NICE guidelines and TOG article, I will follow the NICE. Finished. Okay. Don't confuse yourself. This is a major mistake. The MRCOG curriculum is large, and the sources of MRCOG curriculum are like an ocean. So if you went through this ocean, most probably you will sink. Most probably. Okay. So how can you avoid this? Avoiding this by following the instructions as much as you can. This is particularly in gynecology. The knowledge in gynecology is not so extended, not limitless. They are limited information. But how can you mastering these informations, and how can you utilize minute informations for the max, so that you can gain the maximum benefit from your knowledge? This is applicable for most probably all subspecialties, except the gynecological problems. The gynecological problems, you will find that there is no certain sources for many of gynecological problems. For example, amenorrhea. Amenorrhea, primary, secondary amenorrhea. There is no source. There is no guideline. So heavy menstrual bleeding, we have guidelines. PMS, menopause, we have guidelines. But on the other hand, there are very common situations and topics with no guidelines. Now, we will recommend some proper sources to study from for these topics with no guidelines, clear guidelines. And then you should only revise, study, remember these sources. For example, if I told you about the amenorrhea, you may find 100 proper sources for amenorrhea, but I will provide you with one only source, which is most probably collecting all information, and it's recommended for the exam. So what I'm asking for is just follow the instructions as much as you can. It will save time, it will save effort, and it will put you most probably on the true track. Another thing, it's very important to deal with the exam of MRCOGs, you know, part 1, part 2, part 3 particularly, as a part or your lifestyle. It's not an exam. You are a doctor and you will continue for all your life like a doctor. I think so. Okay. So this is not an exam. This is a lifestyle. The MRCOGs are completely different from other non-RCOGN doctors in the way of thinking, communication skills, systematic approach, evaluation, management plan. All of these points are the characteristics you should gain from the MRCOG studying. So don't, especially now, I will jump for part 3, for example. Now people, when they are preparing for part 3, they told me, it's very difficult exam. The language, the thinking way, how to manipulate people or role players. It's difficult because it's not a part of your practice. It's not a part of your life. You know, after finishing this exams, you will discover that your thinking way has changed, even in finding different solutions in your personal life problems. Okay, so this is what I'm asking for. Don't deal with part 2 exam, part 3 exam like an exam. Make it like a part of your life. You will find it more and more easy. Okay, I think this is a very simple explanation for what we are going to do together in our courses. Dr. Zaib, what is next?
Sir. Yes, sir. Yes, sir. I absolutely agree with you. And in nutshell, what I can add is that, there's always, the kind of recommended source. So like Dr. Hasan said that, if we have many sources for one question, but we have to follow the recommended one. For example, if the same source is available in TOG article and in, the green top guideline. So yes, we will be following green top guideline. That is going to be our priority until and unless the question is specifically from the same source and the question is specifically from the TOG article. Okay.
You know, Dr. Zaib, it's very important as well to know the ranking of your source. Yeah, this is very important. Now, if we have the same topic, nice guideline and green top guideline, I will follow the green top guideline. Green top is the highest body of evidence to be followed. Then the nice guidelines. Then possibly the TOG articles. And after that, all of them, like scientific impact papers, clinical governance guidelines, all of them are in the same rank. So if you understand the ranking, you will find the source easily. Okay? This is very important.
Exactly. And of course, we talk about exam, that how exam is going to be. So of course, we know that Umaira, you have raised hand. Is there any questions, sweetheart? Umaira?
No, ma'am.
Okay, fine. So if you guys have any question, you guys can raise your hand, or you can even write down in chat box. So we will try to reach you. Okay. Okay. So in terms of this exam division, everybody talks like, how it is going to be, and we can solve the exam. So exam is all about the single SPAs and EMQs. So exam, the two papers are there, and there are going to be the SBAs and the EMQs. So SBAs, moreover, they are going to be like, in every 3 hours exam, 50 questions are going to be single best answers, and 50 questions are going to be for the EMQs. Okay, so EMQs, extended match question, and sometimes it is very tricky to solve, because I remember Dr. Hasan, he always used to say that SBAs can be picked very easily, because the answers are going to be very clear. But in EMQs, you need to be tricky, and you have to choose the difficult option. Okay, because in EMQs, you are going to start from option number A to sometimes there can be option number A or option number T as well, from A, B, C, D to, and there are the 3 questions. So of course, for every question you have to scan all options, and then you have to find out your correct answer. So EMQs are very tricky, and for EMQs you need practice, and for EMQs you have to have a very thorough and detailed insight of every guideline, and of course whatever the recommended curriculum is.
Dr. Zaib,
yes, sir?
Dr. Zaib, the differences between the SBAs and EMQs. Technically, the SBAs is fashioned and designed to test one thing, the knowledge. Okay, while in EMQs, it will be designed to test
concept,
the knowledge and applied knowledge. There is a big difference between knowledge and applied knowledge. Okay, I may know the information, but I cannot understand how to utilize this information properly. Okay, so this is why the EMQs is more difficult and require more skills at the candidate level.
Exactly.
To solve this problem through our course, we are trying to, plus giving you the true information, we are trying to give you how can you utilize this information in the right way. For example, a very simple example and rapid example, okay? If I told you a patient with heavy menstrual bleeding, okay? Heavy menstrual bleeding, what is the management, the best management? The knowledge said, Myrina, okay? Myrina, the applied knowledge, you should notice that, am I asking for initial management? The patient is bleeding right now, or the best management? This is the applied knowledge. If I am asking for initial management, if you have a patient now, she is in bleeding attack, if I choose Myrina, this is the wrong option. I cannot insert Myrina with active bleeding. Am I right?
Yes,
This is the knowledge. Applied knowledge, initially, I have to stop bleeding by tranexamic acid. So the tranexamic acid is the applied knowledge true answer. This is the difference. And this is what we are working on within this course. Because, you know, Dr. Zaid, the knowledge is everywhere, okay?
Yes.
Everyone can download the different guidelines and can read them and can memorize every single information. But he get inside the exam or she get inside the exam and never pass. Why? Because of these tricks, applied knowledge. This is what we are really working for together, me, Dr. Zaib, and Dr. Pradnya. This is our aim, to reformat your way of thinking. I'm sorry for interruption. I'm so talkative. So
No.
please continue, my dear.
This
I'm
is
sorry.
very, you know, no. You don't have to say sorry
Thank
at
you.
all. So this is very, I mean, nicely explained that how you are going to, you know, apply your knowledge in terms of applied clinical knowledge. And of course, you know, in single best answers, obviously, you know, there are going to be certain buzzwords, there are going to be certain hints by which, you know, you can pick the correct answer. Okay. So, I mean, in many single best answers, there are going to be questions. What is the initial management for, you know, the anything? Then there is going to be, what is going to be the next best step? Mostly whenever there are, you know, the algorithms for any guideline, so in those algorithm based, you know, the guidelines, mostly question based are on what is going to be the next best step. So of course, you know, whatever is in the question, for example, in the question it is like, I mean, at the step number 1, so, and then they are going to ask you what is the next best step, so you will choose step number 2. But for example, like Dr. Hasan said that, you know, for HMB, if they're asking you what is the gold standard treatment, or what is the initial treatment, or what is the best treatment for HMB, so of course we are going to choose Myrina. But if they are asking about that, you know, the patient is having dysmenorrhea as well along with HMB, so what you are going to choose? So we are going to choose, you know, Myrina is going to help as well. But if it is solely dysmenorrhea with, you know, the painful heavy bleeding, so we may choose the NSAID as well. Okay. So of course, you know, the question can give us some kind of hints, and question can give us, you know, some kind of idea that what exactly the answer is going to be. So in EMQs, of course, you have to scan from option number A to option number T for all three, you know, the question. So in real exam, usually this is kind of rough estimate, because in 3 hours, you have to, you know, the kind of divide your time. Okay, so almost roughly SBAs will have 40% of the weightage of your one paper, so you can solve them in 60 to 70 minutes, and you can give 1.5 minutes roughly to each question. And EMQs, because they have, you know, the more weightage, and they can be solved in 110 to 120 minutes, and you can give 2.5 minutes roughly to each question. Okay, each question means for every 3 questions there are going to be, you know, the couple of options from option number A to option number S. So of course you have to scan all options again and again for 3 questions, isn't it? So it is time consuming, and it will, you know, give you a lot of, you know, sometimes stress as well, that you have to scan. So of course that will come from practice. Okay, exam is 2 papers, Umaira. Exam has 2 papers. Okay. So roughly, the first paper is going to be for obstetrics and the second paper is going to be the gynecology. But moreover, somewhat it is overlapping. So it's not always that, you will find all questions of ops in paper 1 or all questions of, the gynae in paper 2. So sometimes, when I gave exam, ops was second paper and gynae was, the first paper. So in obstetrics, because when you are going to deal with labor, delivery, postpartum, and maternal medicine, obstetrical medicine, so it becomes so challenging. So of course, you have to scan all scenarios, you have to go through all questions again and again, you have to bring, the everything into one. EMQs, sweetheart, EMQs practice is a must thing for this exam. Okay, 100 questions each. Okay, 100 questions each paper. So out of 100 questions, 50 are going to be single best answers and 50 are going to be EMQs. Okay, so this way, the total out of 200 questions, the earlier, almost 5 to 6 years ago, there was a kind of result that you have to pass each, the paper separately. But since 2018, now there is collective result. So I think this is a good thing. So, if you are not that good, because everybody has some, the strong points and everybody has some kind of, the weaknesses as well. Like for me, I'm not a gynae person. I am, the obstetrics person. So of course, I have very strong bases on this, the obstetrics, maternal medicine, because maternal medicine is my, the strong point. So of course, I'll show very much interest. Of course, I have to cover rest of the curriculum as well. But if somebody asks me that, what is your, the strong, the kind of curriculum in this MRCOG part 2, so I will happily say yes, maternal medicine, labor, delivery, postpartum. Okay, so of course, everybody has different interest, but when we are going for exam, so apart from interest, we have to show much, or you can say the knowledge, because we have to pass this exam this way or that way. Okay, so Pradnya, I would like to have your opinion in this thing, that how the curriculum is going to be and how this is going to help. Can you please
Hi, Dr. Zaib.
Hi.
Thank you so much. Thank you so much for the opportunity. Well, basically, I want to say that you and Dr. Hasan have covered basically about everything, how to go about it. All I can say is, other than the whole core curriculum, I think being persistent and studying every day, I think is the most important thing that we need to do to reach the goal of clearing the exam. I think that is really important. Studying one day and then giving up the other day, that doesn't really work. And specifically about the guidelines that we have to do, I think what is very important is making notes out of it and revising those notes at least 2 to 3 times before the exam. And as and when we keep solving questions, I think going on adding important points that you see in those questions to the particular topic, it makes a very good base just before the exam. So I believe each reading should be for the next revision, so the next revision becomes easier, and the next revision, and ultimately by the 3 or 4 readings, we are good to go before the exam. So yeah,
Yes.
these are my 2 cents on the
Yes,
preparation.
yes. Of course, this is very much important, that how you are going to make your own notes. And in next slide, I will be talking about that. And of course, Pradnya is going to talk about the, the obstetric cholestasis guideline, how to read it, and how to extract important points in terms of exam. So just let me tell you a brief overview of the major bulk of MRCOG part 2. So what happens is that the major bulk, like Dr. Hasan said, and everybody will say that the major bulk is green top guideline. Okay, major bulk is green top guideline. Then comes NICE guideline. Okay, this is our major bulk, and this is almost 60 to 70% of the curriculum. Then comes 40 to 30%, 30 to 40%. So what we have to cover in then? These are TOG articles, and basically 3 to 5 years. The topics which are not covered in these 3 to 5 years as well. So basically, we have to cover almost 3 to 5 years guideline, and then we have to go for the articles, the old articles which are not being covered by any recent TOG article or green top guideline or NICE guideline. Then comes BASH guidelines. British Association of Sexual and Reproductive Health, infections guidelines, sexually transmitted infections. Okay, so you don't have to cover almost, the 50 plus infections. You just need to cover important infections which are important in terms of your exam. Then colposcopy guideline, NHSCP colposcopy guideline. This is very important because we have to cover from the scratch for this thing, because you have to be very thorough in the solving, that if a patient is coming with at this step what you will do, a patient is coming at this step what you will do. Then comes contraception guideline again. Okay, this contraception guideline, I think we have got 50 plus guideline. We don't have to cover 50 plus guideline. Okay, but there is no excuse if you don't know anything about COCP use, progesterone only pills use, or progesterone only contraception use. If you don't know anything about IUCDs, if you don't know anything about emergency contraception, if you don't know that how to deal with the missed pills, so then there is no excuse. So at least you have to cover these important, the 7 to 8 guidelines first. And if you are that much interested to do, anything else in the contraception, okay, so don't, then you can cover 50 plus guidelines. But I think as an MRCOG candidate at part 2 level, you should have basics first, and then, if time allows, then you can go for it. Okay. Here I want to highlight one thing as well, because everybody is so upset about FSRH guidelines, BASH guidelines. I want them, I want them. Okay, yes, you can study, you can, cover whatever you want to cover, but again, first cover your bulk. First, cover your bulk, which is 60 to 70% of green top guideline and your NICE guideline. Okay, if you have covered 70% of this bulk, then 30% is this. And out of this 30%, hardly this, the FSRH guidelines are going to be 5 to 7%. That's it, halas. So why put unnecessary, your efforts on this thing? In terms of oncology, they just ask, the basic staging, and then, the basic treatment of every stage. So yes, oncology itself is a subspecialty, like Dr. Hasan said. So if anybody who wants to pursue oncology, so of course, but after MRCOG, you can, join another subspecialty in oncology, and then you can, read more about it. But at this level, your concept should be clear. What is the staging and how you are going to treat that stage? That's it. You don't have to go into much of the detail. So I will again suggest that don't put unnecessary effort on BASH guideline, FSRS guideline. Please, 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 everybody, please cover your bulk first. Okay, your bulk is green top guideline, your bulk is NICE guideline. Okay, so this is very much important. Online, everything is available online. Okay, everything is available online. Green top guidelines are freely downloadable, NICE guideline are freely downloadable, FSRH guideline are free, BASH guideline are free. So what you need, all you need is that how to use Google. Learn how to use Google and how to download. That's it. So for part 2, if somebody is hard copy person like me, okay, so what I do is that I bought a printer. Okay, I bought a printer for myself. So what I used to do when I was studying for myself, that I used to download, that particular guideline, and that's it. I used to, I'm coming to books. Okay, Tabinda, just hang in there. Okay, just hang in there. I will try to give you that what books to cover and what not. Okay, in terms of the textbook, there is no recommended textbook. Okay, all you have to do is green top guideline. You have to cover a lot of books in terms of the questions. Yes, I'm a hard copy person. Yes, I am telling you, Mehra and Anusha, I'm a hard copy person myself. So I bought the very the good affordable printer for myself, and it is still with me. It's like 5 years. For I have started my preparation in 2017. I passed my part 2 in 2018. So can you believe that that printer is still working with me? So whatever I do needed, I just downloaded it on my computer. Okay, then I get it print, and then it is with me. So earlier we used to have only MRCOG part 2 guide group. So I used to run personally the Facebook group, like I still am using, so running. So we used to make the comprehensive schedule. So every day we used to download one guideline, and we used to study that guideline. Okay, yeah. Yes, Alina, of course, on MedExam Expert website, yes, we are giving you almost all list of guidelines and talk articles. Okay. So, I mean, inshallah, you're not going to miss anything. So, but still, if something is missing, something is lacking, you can always, buzz in, and you can always, ask me, Pradnya, Dr. Hassan, the team members as well. We are always, ready to help. Okay. Coming back to this thing again, I will say this is your major bulk, guys. Okay. This is your major bulk, which is green top guideline and nice guideline. So what we have to cover first? Bulk. Okay. You have to cover bulk, isn't it? Where to get authentic material? Authentic material, www.rcog.org.uk. Okay. Nice guideline, same. Okay, Sita? Nice guideline, same. Dash guideline, same. Another easy way to download and search. Go on the Google search bar, write down whatever you need. Like I write infertility and nice. That's it. Then I click, and then that shows that this is infertility nice guideline. If I need anything from RCOG, so I write that topic, for example, OHSS guideline, RCOG. So that Google will show me the RCOG. All right. So this is the easy way to search. So learn how to search, and after being hard copy person, you should have your own computer, okay, or laptop. If you have, you can make your own folders, you can download things. All right. And then you can give you that can be I mean saved in your computer for later study. Some good practice papers, MBRACE report, last two reports are good to do. Consent advice is summary. Okay. So we will do. Anjana, sweetheart, I want to say, because this curriculum is so huge, so of course, being a exam candidate, we always think of that I haven't covered everything. Okay. I haven't covered anything. So it doesn't mean that you have to do each and everything. Okay. Talk articles, some of the talk articles are free on Google, and some of the talk articles are paid. But there are many, the Telegram groups, Facebook groups. If you just, ask, there is, always somebody who is going to help. All right. Yes, Faiza, obviously we will share the key points, notes, and summaries. We will try to guide you through. Okay. Okay, great. Okay, so what is our, the take home message from this slide that we have to cover? Bulk. Okay, you have to repeat it again and again that I have to cover bulk. I have to do green top guidelines, nice guidelines first. All right. So yes, Anjana, I can completely relate to you that how really it happens in exam that because of the curriculum. And so if you have covered your major bulk, so at least you can cover 60 to 70% of your paper, isn't it? So rest of the paper can be sorted out, because by the time you are going for exam, you are going to be so well read, you are going to be so the kind of what I can say, the well learned student. So of course, I mean, there is, the time, there is, the margin as well of, the, what you can say, the margin of error. So don't be so harsh on yourself. Okay. Give yourself, some kind of, the, I mean, space as well, that, okay, I have done whatever I could have done. So of course, nobody can be 100%. Nobody is perfect. Okay. Nobody can be 100% in exam. Again, I will say, okay, nobody can score 100% in all these competitive exams, because in this exam, MRCOG exam, at all exam, in every exam, okay, everybody is like, I mean, kind of, I mean, very good in their respective countries. So of course we are competing with so many good brains. So can you imagine that whoever fails this exam, so they are failing by just the margins. Somebody is failing with 2%, 3%, 4%, 5%, less than 10%. That's it. Okay. So I mean, it's always like, I mean, that you, again I will say that you have to cover your major bulk. Yes, Paisa, it is going to be easy. Okay, it is going to be easy. Okay. So this is going to be the overview of green top guidelines and the nice guideline. Okay, so we have got plenty of green top guideline, and these are archived. Okay, gestational trophoblastic disease, malaria, amniocentesis, venous thromboembolism, preterm labor nice guideline, antenatal steroid guideline. Okay, stillbirth and collapse guideline, operative vaginal delivery, vulval skin disorders, preterm labor, reduced fetal movement. We have got, the 80 plus green top guideline and almost 30 plus green top guideline. Okay, we have got 30%, the 30 plus nice guidelines. So you can imagine that even if you cover one guideline per day, how long it is going to take, how long, it is going to, how far you have to go in your preparation. So can you just imagine? So all you have to do is that you have to stay focused. Okay, you have to, if you have, made a schedule for yourself, or if you are following any schedule, so what you will do in the morning or whenever you are ready to study, so of course you are going to pick that, the guideline. So for example, this is ectopic pregnancy guideline. So of course you are going to read ectopic pregnancy by, the every aspect. Okay, but first you have to cover green top guideline, and then you have to cover, the related ectopic pregnancy TOG articles. We have got cesarean scar pregnancy TOG article. We have got, the ultrasound, the management TOG article. So of course, you have to cover them. Mansha, yes, notes. I'm coming to that. Okay, just hang in there. Just let me tell you, about this. That how many guidelines do we have? We do have, the NICE guideline. You can see that for the NICE guideline, we have almost all medical disorders and labor guidelines. So can you believe? Diabetes, hypertension, infertility, incontinence, mental health, cesarean section, intrapartum care, menopause guideline, postnatal care, surgical site infection, LARC, induction of labor, preterm labor. Okay, so almost, the very important aspect of the guidelines are from NICE guideline. Okay, how many hours to study? It all depends upon, your duty schedule, your, the responsibilities. But I will suggest initially at least give, if you can give, at least give 4 to 5 hours on daily basis. And it should be like, a very religious kind of schedule for yourself. Okay, but close to the exam, at least you have to have, the more time than that. Shortcuts, there is no shortcut to success, my dear. Okay, you just have to be prepared for, the every storm there is. Okay, and MRCOG is kind of, the ocean. Like, Sir Hasan said that it is an ocean of, the knowledge and, the guidelines and all. So yes, of course, this is an ocean. So what you have to be is that you have to be pretty smart. Okay, you have to be pretty focused to, just cover exam in curriculum in very, the good way. Passing percentage for the last 2 to 3 years, it is somewhere between 62 to 65. I think in last 2 exams, it has been 63%. Okay. It has been 63%, 64%, 65, but back in 2017-18 when we gave, so it had to be, oh yeah, professional sailor. it used to be 67, 68 at that time. But I know, because of, the extra demand of this MRCOG, so now, the percentage has been like this. Okay. So, this was all about the curriculum, that how you are going to, study. And these are the TOG article. Apart from 3 to 5 years TOG article, cystic fibrosis, headache, enhanced recovery pathway, nerve injury, spinal cord injury, skin eruptions, hyperprolactinemia, surrogacy, SLE, appendicitis, perforated uterus, abdominal incisions and sutures, abdominal cerclage, myocardial infarction, bariatric surgery, thyroid dysfunction, borderline ovarian tumors, polyhydramnios, asthma, liver masses in pregnancy. So of course, these are, starting from 2009 till 2000, I think 14, 15. So almost these TOG articles are there. So you can see that, they are like, kind of, you can imagine almost all are maternal medicine, cystic fibrosis, headache, skin eruption, spinal cord, prolactinemia, SLE. Can you, just see, myocardial infarction. They have got, thyroid, they have got asthma, liver masses in pregnancy. So almost these all are medical disorder. Okay, so now you can just imagine that how extensive maternal medicine module can be itself on its own, isn't it? So apart from this, of course, you have to cover 3 to 5 years, the module as well. And then comes from where you will do the practice. And that is very important question. Okay, there are SBA books. We have got plenty of EMQ books. And almost, we cover all these books. We have got Andrew Sizer book, Rekha Bhutankel, SBA part. We have got Justin Cooney book, SBA part. Brian McGowan, very beautiful book. Amanda Jones, Mastering, Seema Sharma, Janish Gupta, Succeeding. You have to cover the SPA part. Then comes EMQs again. EMQs, Tahir Mahmood book, Andrew Sizer, P. Sinha. P. Sinha has two parts, the obstetrics and gynecology. Rekha Butankal, second edition, very beautiful book. I personally love this book. Justin Pune, EMQ part, Kalaivani, okay, the get through. So Andrea Pilkington, Succeeding, okay. So in terms of these, the practice books, almost, um, they repeat questions in exam, they repeat topic in exam, sweetheart. So I mean, it's not like that they will repeat as it is, the questions, but of course, the labor is going to be there, maternal medicine is going to be there. So no one can say that this is the same question that has been repeated in the last exam, but of course topics are going to be same. Okay. No. Alina, I think this is more than enough. If you are aiming for this thing, I think this is more than enough and a perfect thing to go. Okay. If we don't buy any prescription, can you pass? Yes, you can pass, of course. Okay. It doesn't mean that you can't pass. All you have to do is you have to stay focused. You have to do, a kind of religious study. Okay. And you have to be very thorough in your preparation as well. Recalls, Sudeep, I will again say, see, recalls, as name says, recall, what you can recall after coming from, the exam. Do you think it is humanly possible for somebody to recall 100 questions as it is? Just give me an answer. Is it yes or no? Is it humanly possible? Everyone, is it humanly possible for somebody? So how can we rely on all these recalls? Can you give me this thing? Okay. So I mean, this is very, yeah, exactly. I mean, this is humanly impossible for somebody that who is coming, from that, the kind of stressful environment, and then, just coming back and recalling. So of course, that recalls can give us idea that, this topic has come. For example, the labor, of course, there are going to be certain things. Okay. So of course, what happens is that, everybody has different capacity, everybody has different, the kind of, I can say, you can say the, I don't know, capacity, I must say. Okay. So if somebody can recall 100 questions, that is good. But I believe personally that it is humanly impossible for somebody that after coming from, that stressful day, and you are sitting and now you are writing the same questions as it is. Okay. So yes, you can practice recalls. Okay. You can get an idea from that, of course. Okay. And for the recalls, what me, Dr. Hassan and Pradnya did in our last two courses, that we did, the recalls, but we did try to cover the complete question. Okay. We did try to cover the complete question, the complete topic. So, I mean, this was Dr. Hassan's, the kind of idea that, we should do this thing. So, for example, if the question was about PMS, and of course, the question was not clear. So, what we did was I mean, thoroughly, we did cover this one guideline in just like, 5 minutes time. Okay. So, for almost in one session, I think we used to discuss plenty of guidelines, plenty of talk articles. And so this should be your, the strategy if you are solving the recalls as well. Yes, some books are, yes, it was in fact a very brilliant idea. It was very brilliant idea, and I think it worked for us. It worked for our students as well, because we did a lot of, the practice. We did a lot of, the rehearsal in terms of, when we were solving the recall questions. So likewise, we are solving we are just revising the complete dog article or a nice guideline or green dog guideline. Yes, 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 it is. Umaira, so yes, there are some books which are only SPA, and there are some books in which, the SPA and the EMQ parts are there, in one book. So of course, you have to cover as a whole. So yes, you have to cover. You have to cover. No, Soumya, there is no essential revision guide, sweetheart. Okay, there is no such thing in our, the part two. Part two is only guidelines, and talk articles. That's it. Okay, Soumya, is it clear? Okay, great. So I hope I have, addressed all these questions in terms of books and everything. Is it clear to all of you? Strategies to solve EMQs. Strategy to solve EMQ is as long as you are solving so many books and so many questions, then yes, it is going to be clear. Hi, Maryada, good to see you. Good to see you. You will get recording. Okay, you will get recording. Soon after it is processed, you will get it. Okay, good. Yes, Sudeep, I will advise solve all these books not only once, twice, but if time allows, thrice as well. Because it will give you overview that how you are going to attempt any question. And yes, discussion helps a lot. So we are running the Facebook guide group, we are running Telegram groups as well, we are doing discussion. Our the talented brilliant mentors are giving a very good discussion, okay, on Telegram and the Facebook groups as well. So you guys can always, and you guys can tag me as well if you guys have any kind of query. Me, Dr. Hassan, Dr. Pradnya, we all are there. Okay, we are scanning. Sometimes we don't even jump, but we know so many things, what's happening and what's going on. See, I will advise you to buy all these books for yourself. Okay, so of course you can add so many things. Okay, you can add so many the points in your own books too. So by the end of your preparation, you will be having your own content. What else you need? Okay, all right, all right. Okay, so these are books. Okay, I think Tabinda, you were very upset about books. Sweetheart, this is Succeeding cover page. This is Tahir Mahmood. This is Androsizer. This is P. Sinha. This is Dekha Butankel. This is Succeeding. This is Brian Magowan. This is Get Through. This is Amanda Jones. And this is Justin Kune book. Okay, so almost you have to buy all these books and you have to cover all these books. I mean, it's not like that you are covering books. It means you are solving questions. That's it. It's not like that you have to cover the book. Okay, got it? Rekha Futankel you have to do. Okay, the new one, EMQ. This is the old, but you have to do the EMQs and SBA part. Okay, all right. For the online sources, of course, you have to buy subscription of Strategy e-learning. Okay, and up to date, no, up to date is not enough. Oh, sorry, up to date. See, my dear, not all books are the new and up to date. Of course, many guidelines have been revised till then, till now. So what you have to do is you have to be very careful in terms of keys. Many keys are going to be based on old guidelines. Yes, Geeta, I will suggest that take Strategy subscription. Okay, because this is going to give you help. This is going to give you overview of the all modules as well. And for example, Grace, talk to me in person. Okay, I know you're from MRCPI course. Are you the same one? I think. Okay, I will help you with that. Don't worry. All right. Okay, so Pass MRCOG is a good source as well. So at least you have to do 2 to 3 thorough question practice from Strategy till exam and put more focus on their explanation as well. But again, I will say that many guidelines have been revised. So of course, you have to refer all the time to your guidelines. Okay, you don't have to revise on all keys which is given in all books. Okay, so Sir Hassan, I would like to have your input on this, the topic, how to successfully fail in an exam.
It's a very smart and funny question.
Yes,
but unfortunately, if you failed an exam, it doesn't mean that you are not good. This is, I have to say this at the beginning before discussing the factors that may affect your performance. If you fail the exam, I'm not saying it's failure, because it's like a marathon. Okay, you may be not one of the best people, but it doesn't mean that you are bad. Now, in the large Olympics, for example, number one will be rewarded by a gold medal. Number two will be with a silver medal, and the third one with a bronze medal. What about number four? What about the person in the competition? He is actually, or she is, the fourth one worldwide in this game. But unfortunately, she or he will never receive any rewards. It doesn't mean that this person, the fourth one, is a bad one, okay? This is exactly the same example for MRCOG exam. It doesn't mean that you are a bad doctor or you are not qualified doctor. It means only you need to refine your knowledge, refine maybe your attitude inside the exam. What about the attitude? Lack of confidence. Lack of confidence is a major mistake in all British exams. It's not related to part 2 or part 1. It's in part 1, part 2, part 3. In OET, in IELTS exam. It's the theme of all British exams. They are not testing only your knowledge. They are testing your confidence level. You know, I will give you a very simple example. MRCOG Part 2 exam. It takes about 6 hours. If I gave you the same exam and give you the time, please answer this exam over 24 hours. Okay? 80% of candidates will pass the exam. So one of the major risk factors for this exam failure is the stress, which leads later on to lack of confidence. So you have to trust your knowledge, to trust yourself, and to trust your mentors. This is very important. Number two, one of the major mistakes that people are trying to be involved in different groups. Now, on Facebook, on Telegram, there are many groups for MRCOG preparation. I should be inside all these groups. I should participate in all these groups. I should revise every single information. This is a major mistake. Finally, you will be distracted and you will be confused. And when you try to revise finally before the exam, you will find yourself lost. Don't do that.
Exactly.
Don't do that. This is a major problem because I know very well the mentality of doctors. Doctors, yes, exactly, Dr. Zaib. When they are still children in the school, I have to be number one. I have to study everything. I have to remember everything. And this is unlogic. No one can do everything. You know, I will tell you a secret. I passed MRCOG, EBCOG, Egyptian Fellowship, MD in Egypt, and I never studied statistics, for example.
Same like me. I never studied.
Okay. Now, yes, now you can see the candidates, the candidates, they are asking a lot of questions. What is the answer of this question, particularly in statistics? It doesn't matter. Even if coming in the exam, I will leave it. I will leave it. No one can do everything, okay? And even the exam strategy, if I try to if I try to explain the mechanism of the exam, you have, for example, 100 questions in the exam. In these 100 questions, you will find 10%. They are extremely difficult, and actually they are in the exam to disturb the candidate. And almost if you spend all time trying to answer these 10 questions, your possibility to answer them correctly is very low. So I have the psychological capacity to be happy to leave these questions. It will never affect my performance. Now, there is about 20 to 30%. They are recurrent, repeated questions. Everyone will answer them correctly.
Correct.
Also, this group of questions will never affect my results because all of people will answer them. So where is the competition? The competition is about 60 to 70% of the exam. Okay? The ordinary average questions. So your mission is to be ordinary average candidate. This is your mission, not a brilliant candidate or a very poor quality candidate. I need to be just standard. I need to be just a regular candidate. To explain more in this point, one of the mistakes and why we are failing in the exam, sometimes I may find a candidate, I will ask him, tell me what do you know about XYZ syndrome?
XYZ?
Yeah, and you know, believe me, he knows what is XYZ syndrome.
Don't tell
Wow,
me.
amazing. Okay, now the next question. Tell me what is the principles of mechanism of normal labor? He is not able to answer. He is not able to answer. Okay, you spend a lot of time, effort to understand and remember and study the tiny, difficult, extremely difficult questions to cover everything. But in this journey, you lose the basics. This exam is for trainees, not for consultants level. So I will attack you, I will examine you in basics. So it's all about basics. So don't try to read a lot of sources, to be involved in multiple groups, to do extreme effort. It's not like this, okay? Following so many or almost every single, this is what I said without reading, you know, I'm not reading the slide, Dr. Zaib, but this is the common pitfalls, okay?
Yes.
Now,
yes.
let me say a very important thing. And this is, we will discuss with everyone before the exam. People are studying until the last second before getting inside the real exam. They are trying to remember and revise everything in the morning. Can you imagine that 3-month or 4-month preparation and you are still in need for a few minutes before getting inside the real exam? What are you doing is, if you did this mistake, what are you doing is you are extremely activating the short-term memory and you are inhibiting the long-term memory, which is essential for this exam. Let me give you a very simple example, Dr. Zaid. If you want to revise contraception, I need to read rapidly the IUCD and Mirena details, okay? And then you get inside the exam, few minutes later. If you have any question related to contraception, your brain, and this is a human brain nature, your brain will translate every question related to contraceptions to the answer of IUCD or Mirena. Because this is the last thing printed in your brain related to contraceptions. Your brain will spontaneously neglect other methods. This is the short-term activation memory. Very, very dangerous, okay? Now, what I need is, before the real exam, I will break the study cycle. If the exam on Tuesday, I will stop studying Sunday night. I will spend Monday, whole Monday, breaking the cycle. So when I get inside the real exam on Tuesday, my long-term memory is now activated. I will remember all tricks Dr. Zaib said in course. Dr. Pradnya did when she answering the questions. Dr. Hasan mentioned before. I will remember everything. This is a human nature. You should understand the principles of your brain working so that you can tackle it. Okay? Don't uh, 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 some people before getting the exam, they are not eating, not sleeping well.
Sleeping,
Not
exactly.
extremely important. You have to sleep, you have to eat well. The exam is physically exhausting. Okay, so myself, before getting inside the real exam, I'm taking prophylactically, for example, painkillers to avoid any headaches or any back pain inside the exam, prophylactically. Okay,
Sir,
so you should
let
yes.
me tell you one thing. One of my friends, she was my study partner in part two. So, I
Uh-huh.
mean, she was so under stress that she had palpitation. She had, a lot of, the tachycardia. So she used to take, I mean, daily Inderal tablet. So she was that under stressed into this thing that, I'm not going to make this exam. I'm not going to do this thing. So she was having, a lot of, the under stress. So I still remember when we were in exam hall, the same exam hall, and she took 2 tablets in 2 papers. So can you imagine?
it's
She
it's
was not
it's
sleeping, she was not, the eating. And I 100% agree with you that, one should sleep before exam, one should eat before exam. I mean, you shouldn't be doing this at all. Your health is your
you
prime
exactly.
priority.
You should believe in
Yes.
destiny. You should believe from deeply from your heart in God, in God willing. It- Do what you should do. Do the
Hmm.
maximum effort, and
Yes.
the results always are not yours. They are not yours. There is something hidden in your destiny, and you should believe in it. My friends, I failed MRCOG twice. Okay, for 1%. I
Me
was
too.
so much, I so much unhappy and so much sad and anxious. I failed part three twice. Okay, also for 1%. It was very, very heartbreaking events in my life. But after a while, if I passed from the first time, I will never be experienced in manipulating this exam, and maybe my career will be far away from mentoring and being a lecturer. Okay, so God prepared me very well to play the role he already planned for me. Okay, so this is almost with all of you. Even if you pass from the second, third time, something hidden, and you should believe that you will pass one day. And now, please, let me ask all of you, including you, Dr. Zaib,
Yes, sir.
do you know anyone starting the journey of MRCOG and reaching, for example, the level of MRCOG part 2 or part 3 exam, and he didn't finish it? I don't know anyone with this. Once you start the cycle, you will finish it one day.
Definitely, one
Okay?
day. Yes.
One day you will finish it. It may be tomorrow, it may be
Yes.
after
Day after
tomorrow,
tomorrow.
but you
Exactly.
will complete
Finish it.
the cycle one day.
Hmm.
Trust this and trust yourself
Yourself.
so you can avoid the pitfalls and you can pass the exam.
Exactly, exactly. So I will just come to this again. This was like, I mean, of course, when somebody is following so many groups, so what will happen by the end of the day? You will be reading thousands and thousands of messages for nothing. You may be lost on in those messages. You may be thinking that where was something which I have to, the focus on? Where is something what I have to study from? Okay. So I think that, if you are a part of, the good 1 to 2 groups, so I think that is okay, because, discussion helps. Of course, the things helps. Okay. So of course, what you have to do is that, I mean, you have to be very focused. And when we say that, it is a kind of focus. So focus means that you are dedicatedly following the one group, or the one mentor or one schedule. So that is enough. What else you need? Being in hundreds of the groups, is not going to give you extra benefit, but rather it is going to cost you your time. It is going to cost you your, the screen time, of course, and it is going to give you headache. It is going to give you, I feel, I have seen so many candidates, their eyesight numbers has been changed. Okay, their, their, they are using, the different numbers of, the glasses now, because they say that our screen time has increased because we are scanning groups. So keep yourself safe as well. Okay, in terms of, like we say that, your health should be your prime, the importance. So you should take care of this thing as well. I'm not saying I'm not against anything. I'm just giving you sincere and the perfect advice for this thing. Okay. Yes, Zahid, I 100% agree with you. I mean, he is my teacher as well, and he is extremely, good in this thing. He always gives us, the very good, the kind of, the boosters in our preparation. And every time, whenever I'm, facing some kind, so I always, look up to him. So I mean, this is very amazing that, he really gives us very good tips. So of course, I mean, I will again say that failing any exam doesn't mean that, we are going to fail, the MRCOG. We have just failed one exam. Okay, so don't lose yourself. Okay, don't just think that, you can't do this. So don't be underconfident. Don't be, the overconfident as well. Okay, Oxford, Tabinda, now this is going to be your take home message. You don't have to study any book. Okay, you don't have to study any book, Umaira, Tabinda. Okay, there is no textbook. Repeat after me. There is no textbook. You just have to cover all guidelines. Okay, you just have to cover all green top guidelines. You just have to cover all nice guidelines and talk articles. Yes, Sudeep, 100%. Okay, so please don't run after so many sources. Just stay focused, and inshallah, you can cover properly. So here, me and Pradnya, we will try to give you, the idea that how to make your own, the small notebook and how to jot down your important points. Okay. Um, yes, Mariada, 100%. I agree with you. I agree with you. Seriously, his voice helps in exam as well. And I have been his student as well. I know, that, how seriously it works. So this is the key for preparation. This is going to be general advice. You have to organize yourself. First, you have to know your syllabus. You have to make your folders of all modules. Like I said earlier, that for every module, that is, you have to bring about your, the things in one folder. 5 months are more than enough to study. Okay, 5 months are more than enough to study. Just stay focused. Please, this is going to be my take home message as well, that you need to be focused. Unless you are focused, you are not going to cover anything. Okay, focus means that you are reading every day. You are, doing your own, the notebooks. You are listening to lectures if you are in a course. Okay, and you are following, our advices. Of course, we have, a lot of experience to teach. Dr. Hassan is more senior than all of us. Okay, than me. I'm in this business, teaching business for like, 5 years for now. Okay, so of course, Pradnya is there. She is also teaching. So of course, we will be guiding you through that, how to go and how to, not follow. So schedule is very much important. Have a good grip on and salient points from guidelines and talk articles. Emphasis on facts, figures, percentages, like what is the incidence, what is the recurrence, what is the prevalence. Okay, this is very much important because MRCOG part 2 is all about numbers. So of course, you have to memorize numbers too. And being a doctor, I know almost all of us are a little bit poor in, memorization of numbers. So what you have to do is for that, then you have to revise, revise, and revise. Okay, you just have to revise. Yes, Elena, you are going to have mini schedule. Okay, so after this, we are going to run, the big marathon of the course. So of course, we are going to share the mini schedule before every session. So, and you are going to cover on daily basis. Plus, this is the key. Post as many questions as possible from all available pool. And available pool, I have shown you earlier. We have got plenty of books and we have got, the plenty of sources available. Okay. All you have to do is copy paste, and copy paste and just practice. So what you can do is, for example, you are like 100 candidates in one group. So what you can do is, if everybody posts two questions every day, so what will happen? By the end of the day, you will have almost, the kind of 100+ questions to practice. So what you will do, you will just open your Facebook group one time. You will just scan all questions. You will answer, then turn off the notification and come back afterwards. Okay, come back afterwards. All right. Thank you so much, Preeti. If you are the same, Preeti Patil, I really miss you. Thank you so much for showing up. Really, good to see you. Good to see you. Okay, so discussion helps discuss. Whenever there is any confusion in topic, open resources mean recommended resources, and cross-check latest blog article and guidelines for reference. Make your own small notebook. Note down all important points from guideline or talk you read. Discuss with your study partner if possible, and this is not hard and fast rule. All right. So if not, you can take part in discussion on group. Unless what they say is that unless you are hungry, okay, unless you are hungry, you won't be asking for food, okay, unless you have this desire to study. So of course you can't get any guidance, you can't get anything unless you ask. Okay, so you have to do that, all right, unless you are thinking that see, when I was studying with my study partner, I am FCPS from Pakistan as well. So I used to have one of my friends. Okay, her name is Sharda. So I mean, we used to study. So she always used to ask me, please mind me because I'll be telling in Urdu. So I mean, please, if anybody doesn't understand, I will translate it. So she used to say, when I used to answer something, she तूने कहाँ पढ़ा ये? बता मुझे source कहाँ पर है ये ना? Source कहाँ लिखा है ये ना? कहाँ लिखा है मुझे बताना. See, okay, when there is no when there is no why, when, why, and what, you can't, get enough, the chance to explore that topic or something. So that why, that where, led us to one of a good discussion where we used to fight with each other, where we used to study with each other, and Alhamdulillah, today we were three friends, and we all are FCPS today. I am MRCOG and plenty of others too. So of course, we are there. Fartun, we used to fight on, this thing that, where it is written. If I'm answering, my answer is A, your answer is B. So I am asking you, no, I am 100% correct. So you will say that, where is the reference? Where is it written? Just give me the reference where it is written. Show me the reference. So once you have this, the kind of attitude in your study, so you can't, get a real, the answer. Likewise, if you are in any group, okay, so what you have to do is always ask for reference. Don't ask for key. Come on. There are a lot of keys. Everybody is asking for key. By the end, sometimes what happens is by the end, my mind is about to explode just looking at key, please, key, please, key, please. Oh, come on. I have posted this question for the sake of discussion, not for the sake of keys. Okay. So please, I mean, come out of that zone where you just need keys. Come out from that zone. Try to explore the topic. Try to see the question as a whole. All right. So just try to think of, where it is written. Where is this written? Is it written in talk article? Is it written in green talk article? So you guys can always ask that. Can you please tell me that, where it is written? Or can you please, I mean, put that, that screenshot that where it is written. All right. So please, make it a habit rather asking for key. I mean, key can be, so many. Then somebody can say Sanu key, if there is nothing. So, I mean, okay, there is nothing. There is no key at all. Okay. Yes, Umaira, I will share. Okay, don't worry. And the last thing I want to add is that, your first reading should be within 3 to 3.5 months. Okay. First reading of all green top guidelines, all nice guidelines, along with, the few talk articles as well. Okay. Talks are kind of, the stories. Talks are like personal opinion. If I'm, remembering something, yes, Partun, I 100% agree with you. The keys are changing, because of the recalls. Of course, the recalls are like, I mean, partly recalls. And of course, everybody has different perspective. Somebody can say, okay, this was that question, this was that question. So we can't say that, I mean, those are 100% question, okay, the 100% correct question. So at least your first reading should be within 3 to 3.5 months, and later on you have to revise them till your exam. Revision is must. If you don't revise, you aren't going to, be a good, the kind of a candidate. because if you don't revise, you are not going to supplement your, the study. Okay, so be positive towards what you learn and try to absorb it with examples, with references, with reasoning. Like I said, when, how, and why. Key is answer. Key mean answers. Okay. Key means everybody is asking for what is the key of this question, how we are going to solve this question. That is key. Okay. So you have to be positive. You have to be positive at all times. Okay, so here we will jump in and we will try to be, a help in your preparation. Okay. Study partner is difficult to find, of course it is. So it's always like, a hit and trial method. You can just try and you can just, the kind of, because everybody has different stamina, everybody has different attitude, and sometimes, you click to the right person. Okay, so it doesn't mean that, that person or that, the particular person is not good. So of course, you can just kind of start over. If you think you are not good, so we all are grown up, we are not like kindergarten kids, so we can always excuse, but in a nice way. Okay, don't be harsh, don't be rude, don't be the kind of, the intimidating person as well. So just be yourself. Okay, just be polite in this journey. That is going to count and that is going to help you, trust me, because this is very tough journey and nobody knows. Nobody has, perhaps nobody has seen me. I perhaps I don't know you. You are from other corner of the world, I'm from other corner of the world. We all are connected through internet, we all are connected through our voices. That's it. So be kind, be humble. Okay, we just try to help. If you will help today to somebody, somebody is going to help you tomorrow. And this is a cycle. I'm sure everybody knows that this is a cycle. All right, so this is where we will jump in for the July exam. So of course, how many questions of percentages or numbers, Zahid? There is no 100%, the kind of idea, but roughly at least 7 to 8 questions or say 10 questions can come. Okay, at least, the 10 questions can come from, the directly numbers. For example, I'm coming to that. Okay, notes, don't worry, I'm coming to that. Okay, and we will jump and we will try to help you in terms of, the course. Again, I will say, the purpose of taking this session is not, always asking you to join our courses. Purpose of this is that at least, we can help to the people who can't study on themselves. Okay, who need some kind of motivation, who need some kind of supervision. Okay, so if you guys, want to join, you are more than welcome. Even if you don't want to join, our free groups are always there, our mentors are guiding there. Okay, even me, Dr. Hasan, Dr. Pradnya, we are always there. You guys can tag us. Okay, you guys can, ask us for any query there is. Important topics for percentages, it can come from any topic, sweetheart. Okay, nobody knows, nobody is from RCOG. Okay, that is from RCOG. So this is our job as a candidate, that we should study everything. All right, so of course, we will be giving you live sessions, like we are having sessions today. So that is going to be on, the modules, every modules. So we will distribute modules amongst ourselves, me, Dr. Hasan, Dr. Pradnya. So after every module, you will be having a mock. Okay, you will get summaries, you will get talk summaries as well. You will get, the final mocks exams too. You will get nice and GTG question banks too. Okay, talks, question banks too. Plus, this is an essence. This is an essence of our course, because here we laugh together, we cry together, we fight on questions. Okay, we do try to help each other. And I'm sure I can see many candidates are here. Maryada is here. Yes, Maryada, if you could, say something about us, our teaching, and how you have had, the experience with us, because study room really helped us in revision and everything.
Yes, ma'am. First of all, good evening, ma'am,
Good evening.
Dr. Pradnya and Dr. Hasan. I'd be missing all of you a lot because we had a wonderful 4 months journey. And I feel that, ma'am, the course is so vast that if we try to do it ourselves, we kind of get lost. We don't know where we have to focus. We don't know which part we can just skip. So what happens is we tend to focus on unnecessary details. We waste time, and the important ones we skip. it. So I think joining the group has helped me a lot, ma'am, because it
Yes.
has helped me to have a focused study. Like certain things that was I thought like I knew, but when I joined the course and all of you taught, so like there was more clarity to the topics. May it be like urogynecology or CTG, like the intrapartum part, ma'am. Like we've
Mm.
been doing that in our MD days, but when you taught us CTG, I felt like I didn't know that before. Like so many points were important. So it's very, I think it's important to join the group, ma'am, for the focused study. And MedExpert team has been very kind and very extremely helpful because there's like 24/7 service. Even if we join the free group or the guide group, the colleagues are also very helpful whenever we
Yes.
are in any confusion regarding certain things. So our friends also, they help us like, okay, this is from this reference and this is the thing that we need to
Mm.
study. And whenever we tag you, Dr. Pradnya and Dr. Hasan, they're always ready to help. So I'm very thankful to all of you. I've not got the opportunity to thank you, all of you, and the expert
Thank you
team.
so
And
much. Thank you so much. It really means a lot. And thank you so much for showing up. And really, really means a lot. Yes. And I also miss you guys. You know, we really had very good time. And by the time we are like coming together in one course after 5 months, 6 months, I still remember, the Maryada texted me 2 days ago, ma'am, I missed you. I really want to, listen to your voice. I said, okay, I'm here. You can always talk to me. So thank you so much, Maryada, for showing up.
all the mentors, like you really push us to do good, ma'am. Like you all work so hard for us that we have to work hard for ourselves.
Yes, 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 definitely, definitely. Thank you so much. Thank you so much, Maryada. Thank you so much. Means a lot. And yes, and so of course, we will be guiding in terms of the focus mentoring. But again, I will say that these summaries are for your help. Okay. So if you think that you can't read it, I mean everything on yourself, always take help. But we as a mentor, we will always advise that please at least once go through the guidelines. Okay, go through the guidelines yourself. So of course it is going to help you, and then the ready-made material is also there to help you as well, so you guys can always go through. So like I said that we are going to be with you for July course, Dr. Hassan, me, Dr. Zaib Qureshi, Dr. Pradnya, we all are MRCOG, and me and Dr. Hassan, we both are examiners as well. So perhaps you guys will be seeing us in part 3 too as an examiner. So I think that is going to be a good deal. At least you will be familiar with us, and inshallah, if you go through this part 2, so you will be with us in part 3 as well. So we are really hoping for everyone who is in this MRCOG part 2 journey to pass this exam and to become MRCOG like us. Okay, always remember, we always say that if we can do it, you can also do it. Okay, so of course is starting from today, and from tomorrow we will have our mini schedule posted in our study groups, and we will be on our this marathon for July part 2, and the course is going to be till July. So if anyone who is interested can always text our team, and text us as well in person, or even not the course, even if you need any kind of guidance, our doors are always open. Okay, so don't hesitate in asking anything. There can be some kind of the delay in answering, there can be some delay of, because we work as well, I work as a consultant too, Dr. Pradnya works as consultant too, Dr. Hassan is a urogynecologist as well. So of course there can be some delay, but whenever we will see the message, so of course we will try to help you. Okay. Oh yeah, sure, Umaira, you can. Okay, you can. No problem. How to study the guideline? Yes, I'm coming to this. So schedule is must. So as a med exam expert team, we are helping you sail through this tough journey and long journey. So I hope we are going to see you if you guys join us. So this is going to be our schedule. This is going to be our schedule according to the modules: early pregnancy problem, urogyne, and Dr. Hassan is a master in urogyne. Antenatal care, maternal medicine I will cover, and maternal medicine, Dr. Pradnya and me, antenatal care we will cover in 5 sessions. Can you see that we will have extensive discussion on complete package of maternal medicine. Okay, infections, obstetrics, gynae-oncology, Dr. Hassan will cover. Then gynecological problems, sexual reproductive health, subfertility, management of labor delivery. Like I said that I am a the good, try to be a good obstetrician. So I will try to, give you overview about it. And then postpartum problems, core surgical skills, and almost all modules. And in the end, we will have some query discussions, groups as well, and almost everything. Okay. uh, I learned from someone that even after passing, see, MRCOG is undergraduate degree, or not undergraduate, no, the postgraduate under the specialist degree. Okay, MRCOG is membership exam. So after MRCOG, you can't be a consultant directly over there. Okay, this MRCOG is a kind of specialty, the trainee exam, and you are going to become consultant after if you pass your the specialty trainee year 5 and 6, and then you can be the independent consultant, of course. But in your countries, if you are working in Pakistan, India, Bangladesh, Nepal, in our countries, so yes, we can utilize this degree and we can work as an independent consultant. Okay, so that is the answer. And for candidates, somebody has texted me that after FCPS from Pakistan or Bangladesh, can we do this MRCOG, and is it going to help us? Yes, it is going to help us. For me, when I started off this MRCOG, I was FCPS already, and FCPS means that, of course, I was working as a consultant in the private hospital, and in fact, I was working as a registrar, full-time registrar. So I did part 1 when I was full-time registrar. So I used to have my Oxford book, Oxford revision notes with me all the time. So I used to carry. Then when I was in part 2, so yes, I was working as a registrar as well. So I used to carry, the one guideline daily in my, the purse or handbag. So I used to carry because I bought my own printer. So I used to print it up, and then, I used to take it. So wherever I, get time, so I used to read it. So of course, we all are working. I know this is hard, and this is hard to manage as well. So this is the only way you can do is you can push yourself, you can tell yourself that you have to do is, and you can do is. Okay, Umaira, I hope I'm clear now. All right, all right. So any exam from your own countries, it is going to be a base for you to sail through this MRCOG, because of course you have clinical knowledge. Like me, I was, the FCPS, like Dr. Hasan, he was also MD at that time. Dr. Pradnya is MD. So of course, it gives a lot of, the good kind of idea if you are jumping into MRCOG. So we will be giving, the mini schedule as well, like for antenatal care, there are going to be topics for every day. For example, this is from January schedule, but for July, we will also give, and we will try to. Wow, good to see, good to see. And I really, appreciate for the people who are aiming for second degree. Okay, trust me, this is going to, the polish your skills, polish your knowledge. I have felt a gross difference in my counseling. I have felt gross difference in my management of the patients after doing MRCOG. Okay, so trust me, this has really helped me in my, the clinical practice as well. Plus, this is going to be the essence. Last 2-3 sessions are going to be important exam question revision. Plus, biostatistics revision is going to be there. So our, the biostatistics queen, Dr. Desiree. So she is going to take, the biostatistics session with you guys. She is very much expert. Like, Dr. Hasan said, he never did biostatistics. I never did biostatistics in my life. Dr. Pradnya never did. But, luckily we got through this exam. So it doesn't mean that you have to focus the 95% of the exam, and you will just focus on 5% of the exam. But of course, we will give you this opportunity to have an exclusive overview on biostatistics. Okay, so almost, this is going to be your essence. So Pradnya, are you there?
Hi, yes, I'm here.
Yes. So I would like to, ask you to just, tell the students that how to read a guideline and what exactly to focus on.
Well, sure. So first thing before reading a guideline would be to go through the whole thing at your pace, take your time, read it, jot down the important points. And, next time, whenever you go through it, make sure to go through the notes that you've made when you read for the first time. And as in when you keep coming through new things through the Telegram groups or Facebook or whenever you're solving questions, keep on adding to it. And I would suggest that read similar guidelines at a place. For example, if you're reading HMB guideline, heavy menstrual bleeding guideline, read the TOG article for fibroid along with it, read the postmenopausal bleeding along with it. So everything from a similar topic is concise and together, so it's easier to revise.
Exactly. Exactly.
And
And
regarding
let me just tell you
yeah.
briefly, this is my handwriting. If somebody can see, this is how I used to make my own notes. Umaira, if you are there, Tabinda, this is for you. Okay. For example, I have read shoulder dystocia guideline. I have just written incidents. Barza, are you there? Barza, are you there? Okay. Okay, fine. So this is for you. Epidemiology doesn't mean that you will go through complete statistics. No, you have to do the incidence. For example, I will pick incidence. I will pick the shoulder dystocia definition. I have written down the recurrence. Then you know the important percentages: PPH, third degree, fourth degree perineal tears, brachial plexus injury. What are the risk factors? So this is my personal, you know, the kind of notes. So I used to make, you know, I used to write like this for myself. And I mean, like this, you know, I did try to summarize, you know, this on this small notebook, and almost on 2 pages shoulder dystocia is there. And these notes are still with me even after becoming MRCOG, even after becoming, you know, this mentor. But you know, I am taking, you know, the all help from my own notes till date. Okay, although I have so many things, you know, the PowerPoints, I have so many notes, I have so many, you know, the PDF, but still, you know, this gives me a lot of satisfaction that, you know, yes, I know I have read this guideline and I know this is 100% authentic. There is no I mean, such mistake. If there is any kind of mistake, I will, you know, download, I will go through the you know, the website, I will just open the guideline, and then, you know, just I will see myself. Until I see something from my own eyes, I won't believe anybody. And Maryada knows this thing, that in even in study room when we used to discuss, I used to say, where is the reference? Can somebody show? Where is it written? Because unless you are sure, unless you know that this is written in any guideline, this is not going to help you at all. Okay? Barza, Umaira, is it clear to you both? Hmm? Okay, that's great. See, for example, this for shoulder dystocia, I did success rate of all maneuvers. I know McRobert has 90%, all four has 83%, posterior arm injury is 2 to 12%. So all important percentages in one thing. So can you see that, you know, I mean, with this, okay, I'm done. My shoulder dystocia guideline is done. Okay, so this is how you can make your own notes. And I think Dr. Hassan has told us, you know, when we were his students, so he used to tell us that, you know, make a note of percentages, a separate note of percentages. So that is also one of the technique. If you want to write down, you know, your all percentages, so buy a notebook, make separate, you know, the folders or separate portions. So for like percentages, you have given a percentages, and then, you know, write down whatever you read, write down. And later on you can highlight, you can, you know, the compile, you can go through. So if somebody is asking you, just open that folder, open that portion, and just look into, you know, your percentage collection. Okay, so there are so many ways, you know, you can always simplify, you can always, you know, take help, you can always ask. So I think this is going to help you. Is it clear, everyone? So Hassan, would you like to add something to it?
Yes, yes, Dr. Zaib. Actually, I'm following what you said, and it's perfect as well. But you know, the personal notes and to do your own summaries by yourself has a very important advantage. It will help you in the final revision to just read your summarization and to avoid trying to read all other sources, the large sources. This is a very critical point. You will remember what you wrote by yourself.
Exactly.
You will remember your tricks, your tips, which are important for your success. So you need, even don't depend on what I did. Don't depend on other summaries. It will be helpful at some extent, but no one can remember the details better than the details he or she already created by themselves. Okay, so this is very important thing, and I believe everyone can do it. It's easy if you following the schedule, the main schedule, and the other fixed schedule of sessions. And after each session, you try to build up your notes. You will, at the end, find yourself, oh my God, I had a lot of summaries, a lot of precious information, okay? And this will be your way to pass this.
Together. Does that sound good?
Yes, 100%.
Yes. So I'll start with obstetric.
Wow.
Thank you, Dr. Zaib.
This is so beautiful. MBBS, MS, DNB. Wow. I mean, this really, is beautiful.
Thank you, Dr. Zaib. Thank you so much. So, well, before I begin, I'll introduce myself. I'm Dr. Pradnya. I'm a consultant. I'm basically from Bombay in India. And I've been with MedExam Expert since 2020 now, initially as a student and now as a mentor. Both Dr. Zaib and Dr. Hasan have been my mentors and guides, and I'm eternally grateful to them for always being there for me and for making sure I'm here. And yes, so on that note, well, this is a quote that has stuck with me since I was a student in school, and my sir had once said this to me, and it makes sense still. Dreams are not what you see when you sleep. Dreams are things which do not let you sleep. And MRCOG was one dream that I really wanted to achieve. And thanks to Dr. Hasan and Dr. Zaib, it's been possible, and with relentless efforts and lots of hard work, lots of perseverance, lots of persistence. Well, I think Dr. Zaib and Dr. Hasan have told exactly what to study and how to go about it. I will just tell you what we are going to read today. We are going to do the obstetric cholestasis guideline. Basically, I've summarized the whole thing from the Green Top guideline and the TOG article. And basically, this is how you're supposed to make your notes, just not on the PowerPoint presentation, on pen and paper. Then we will be solving some single best answer questions and some extended match questions. And towards the end, if you have any doubts, I will be taking your questions and answering them. So let me know if I'm clear and if I'm audible, or you want me to go slow. If there's any problem, do let me know in the chats. All right. So obstetric cholestasis is basically also known as the intrahepatic cholestasis of pregnancy. It is great, Dr. Sabha. Thank you so much. Right. So it is the most common pregnancy-specific liver disorder, typically presents in the third trimester. It presents with pruritus, that is itching, which is mostly confined to the palms of the hand and soles of the feet. The clinical importance of obstetric cholestasis lies in the potential risk to the baby and to the mother. To the baby, it could lead to preterm birth, which could be spontaneous, or because of some interventions or iatrogenic, it could also lead to stillbirth or fetal death. For the mother, it could lead to sleep deprivation, which could lead to morbidity in the mother. So basically, it is characterized by elevated maternal serum bile acids, which is pathognomonic for obstetric cholestasis, and it is also associated with liver function tests. So more on that later. Let us look at a few incidences first. So these are very, very important incidences, and obstetric cholestasis is famous for its single best answer questions. So the incidence in UK is 0.7%, or 7 in 1,000 pregnancies will be affected by obstetric cholestasis. When you look at the worldwide incidence, it is 0.2 to 2%. In the UK, twice the number of Indian or Pakistani origin women will be affected, and their incidence will be 1.2 to 1.5. In Chile, 2.4% of pregnancies are affected, which is quite high, and 5% of Araucanian Indian origin people would be affected. So if they ask you the highest incidence, it is in Chile. This prevalence is mostly affected by genetic and environmental factors in 10 to 15% of women, and a family history is seen in almost 14% of women. Now let's look at the risk factors. So there's a way to remember this. Family history would be obvious. The second would be older women. We can remember like older women, usually have an IVF pregnancy. IVF pregnancy usually leads to multifetal pregnancy. So these three could be linked. A history of gallstones is specifically for obstetric cholestasis, and hepatitis C infection. Well, the etiology of obstetric cholestasis is largely unknown. We do not know why it happens, but it is seen that studies have told that it could be because of cholestatic effect of reproductive hormones. Yes, correct, Samina. Yeah. So it could be because of cholestatic effects of reproductive hormones. So there were studies that saw that it was seen more in women with twins or multifetal pregnancy after taking oral progesterone treatment to prevent preterm labor. It was seen in third trimester most commonly, and there was a recurrence of symptoms and biochemical cholestasis with OCP use. They came to a conclusion that all these conditions had raised estrogen, progesterone, or both, and it was most likely because of the cholestatic effect of these reproductive hormones. So how do we diagnose obstetric cholestasis? There would be unexplained pruritus. Unexplained means you cannot really find out a reason why the patient is having itching. There will be no rash. You won't really be able to see anything. This pruritus is most likely confined to the palms, the soles, and it is more severe at night. Now coming to the biochemical investigations, there would be abnormal liver function tests and or either raised bile acids. The range that we're supposed to give importance to is the pregnancy specific range. And both of these would resolve after delivery. This is what the green top guideline tells you about the definition of obstetric cholestasis, and this is how you're supposed to diagnose it. A few other points about itching in pruritus. Pruritus affects 23% of pregnancies overall. So overall, the incidence of pruritus is 23%, but not all pruritus would be because of obstetric cholestasis, right? It is usually present in the third trimester. 80% of women will present after 30 weeks of gestation. Earlier onset is seen in women with multifetal pregnancy. Like we said, increased estrogen progesterone can lead to cholestatic effect, and therefore there could be an earlier onset in women with twins, right? There is no specific rash for obstetric cholestasis, so there will be no typical rash that you will see. But yes, if a patient comes with excoriation marks and pigmented lesions that resemble prurigo, basically the marks that you see after itching, also known as dermatographia artifacta, so these would be most likely because of obstetric cholestasis. So these are all the buzzwords: the pruritus, third trimester, pruritus confined to palms, pruritus confined to soles, increased at night, increased in the third trimester. If you hear all these things, please think of intrahepatic cholestasis of pregnancy or obstetric cholestasis. I hope this is clear till now. If there are any doubts, do let me know. Well, there would be other constitutional symptoms as well. Constitutional symptoms of cholestasis, that is dark urine and pale stools. Also, there could be right upper quadrant pain, that is pain confined because of the liver, stretching of the liver. Now, jaundice is very rare. It affects hardly 10% of women with intrahepatic cholestasis of pregnancy. Other causes of itching and liver dysfunction should be excluded to come to a diagnosis of obstetric cholestasis. Women who have persistent pruritus and normal biochemistry should keep repeating their LFTs every 1 to 2 weeks. This is an important single best answer question. Please remember this. Now there are differential diagnoses of deranged liver function tests and pruritus in pregnancy. If there is a rash present, please think of something like polymorphic eruption of pregnancy or PEP or pemphigoid gestationalis. If there's a rash present and there is abnormal liver function test, do not think of obstetric cholestasis. Now let's come to the serum biochemistry. This is very important. The LFTs would usually be abnormal. The serum bile acids are the most sensitive and specific marker. It is an important single best answer question. But having a normal bile acid does not really rule out obstetric cholestasis. So what this means is, even if there is a normal bile acid, the patient could still have obstetric cholestasis. It could be given to trick you into believing into something else. Now coming to alanine aminotransferase, this is more specific as compared to aspartate aminotransferase. Bilirubin is raised only approximately 10% of women, like we already discussed. And coming to alanine phosphatase, this particular hormone is produced in large quantities by the placenta and is usually elevated in normal healthy pregnancy, and therefore this is not specific for obstetric cholestasis and not to be considered as a part of diagnosis. Now coming to other investigations which are important, we have to do a coagulation profile, and we see a prolonged prothrombin time in almost 20% of cases, and our treatment also depends on this, which we will have a look at later on. It is also advised to do screening for gestational diabetes mellitus, to screen for hepatitis A, B, and C virus, cytomegalovirus, and Epstein-Barr virus. The liver ultrasound should be performed to exclude other causes of cholestasis. Also, we would need a liver ultrasound to look at the gallstones, because almost 13% of women with intrahepatic cholestasis of pregnancy will have gallstones. Other investigation that we need to do is anti-smooth muscle antibody and anti-mitochondrial antibody to rule out other autoimmune causes. Now, how do we monitor these obstetric cholestasis? So if it has already been diagnosed that this patient has obstetric cholestasis, we would measure LFTs every week until delivery. And along with that, we would also be doing a general review. We'd be doing a blood pressure measurement, and we would be checking the urine. If pruritus is present and the LFTs are normal, we would repeat it every 1 to 2 weeks. This is when it's diagnosed, we are checking it weekly. When it is not diagnosed, and if there is only pruritus, we are repeating every 1 to 2 weeks. Please see how these two are different, and please make a note of it. Now coming to risk of stillbirth. It is well known that obstetric cholestasis has a risk of stillbirth, but the exact risk is not known. It is likely to be a little more than the general population. The perinatal mortality rate from obstetric cholestasis is 5.6 per 1,000. Again, an important single best answer question. These incidences from obstetric cholestasis are very important. Now coming to the other risks that are associated with pregnancy, which is complicated by obstetric cholestasis. Premature birth, which is mostly iatrogenic. That is, we deliver the patients early because of some complications, and this is seen in 7 to 25% of cases. Again, a very important incidence. Meconium passage is a complication of obstetric cholestasis, seen more commonly in preterm obstetric cases as compared to term obstetric cases. In preterm, it is seen in 25% of the cases, and in term 12. How we can remember this is 12 is almost half of 25. So for preterm, it would be 25, and for term, it would be half of 25 or around 12. It would be 12.5%, but you can remember 12. The other risk would be fetal distress. There's an increased risk of delivery by cesarean section, that is 10 to 36%. Perinatal mortality is, yes, it is given that it is 11 by 1,000, but that was an older study. Towards the end of that paragraph, Samia, right? If you see, it is mentioned that it is 5.6 per 1,000. I will share the reference with you. Right. Now coming to delivery by cesarean section, it is seen in 10 to 36% of cases. Sure, you're most welcome, dear. Postpartum hemorrhage is seen in 2.4% of cases after vaginal delivery and 6.3% after cesarean section. Now, the mechanism underlying adverse perinatal outcome is very uncertain. Nobody knows why it happened, but there is a link with the circulating bile acids. Bile acids more than or equal to 40 micromoles per liter. After this, there's an adverse event which shows a linear relationship with bile acid levels. In the sense, one second. So in the sense, it is with 1.2% increase in risk for every 1 micromole per liter, which increases after 40 micromoles per liter. What I mean to say is, After 40 micromoles per liter, there's a really linear relationship with the serum bile acid and adverse pregnancy outcome or perinatal outcome. Can fetal death be predicted and prevented? A simple answer to this would be no. Fetal death cannot be predicted and it cannot be prevented either. But what we can offer is only continuous fetal electronic monitoring. That is all that we can offer. There are no biochemical tests that can decide it. There is no antenatal fetal monitoring that can decide or predict it. No ultrasound or CTG. None of these are reliable. But yes, obstetric continuous electronic fetal monitoring is offered during pregnancy. Yes, consultant-led care is there. I'm coming to antenatal management in some time, Geeta. While fetal death is usually sudden, there is no evidence of placental insufficiency. There is no growth restriction. There is no oligohydramnios. The umbilical artery Dopplers are not all normal. Basically, the death does not happen because of uteroplacental insufficiency in obstetric cholestasis. There are some studies that say that the raised bile acids lead to cardiac arrhythmia in the baby, which leads to fetal death. But nothing is known for certain because we do not know the cause. We cannot diagnose why it happens and we cannot predict it. This is a very famous question that they ask, can you predict fetal death? And the answer is a big no. Well, now coming to the antenatal management, here is your answer, Dr. Geeta. Yes, it is a consultant-led care. The delivery has to happen in the hospital. There is no evidence that any specific treatment improves fetal or neonatal outcome, but we do have some symptomatic management that we can offer to these patients. In terms of pharmacological management, ursodeoxycholic acid or UCDA is known to improve pruritus and liver function in women with obstetric cholestasis. Although it is not licensed for use in pregnancy, it has been used widely, and there has been no cases of teratogenicity or congenital abnormalities in this case. Rifampicin, which is a famous anti-tubercular drug, and it has been used in pregnancy, and there are studies that say it is safe. It reduces pruritus and it enhances bile acid excretion. So this is the second drug that can be allowed. Chlorpheniramine, which is an antihistamine, it will help people sleep at night. It will help patients sleep at night. It will provide some sort of sedation, but it has no significant impact on pruritus. This again is an important single best answer question. It comes a lot of times. Topical emollients again can be given for symptomatic relief. Some women find help with it, but again their efficacy is largely unknown. Now, role of vitamin K. Vitamin K is indicated only in cases where the prothrombin time is prolonged. Like I mentioned, it is prolonged in 20% of the cases. This is the condition wherein you will be advising vitamin K. Also in cases of steatorrhea. Basically, in cases of steatorrhea, there will be loss of fats, and vitamin K is a fat-soluble vitamin, and it is required for formation of coagulation factors, and its loss can lead to increased bleeding in the baby and the mother, and therefore we need to replace it. And how do we replace it? With the help of water-soluble vitamin K, that is manadiol sodium phosphate. The dose is 5 to 10 milligrams daily. This reduces postpartum hemorrhage and fetal or neonatal bleeding. This is the indication of giving vitamin K. Postnatal vitamin K can be given to the babies as usually indicated. Well, what's not indicated is cholestyramine, S-adenosylmethionine, dexamethasone, activated charcoal, and guargum. These are not indicated, though they have been used initially. There are studies, but basically in clinical practice, none of these are to be used. Now coming to antenatal monitoring. Different units have different protocols for monitoring these babies. Some do cardiotocography and some monitor with throat scans. Just a second, there's a question. Is prothrombin time normal? If prothrombin time is normal, vitamin K can be used, but you need to counsel the patients about a little increased risk of complications. Norrin, that is vitamin K that is given to the baby. I was talking about tablet vitamin K, which is a water-soluble tablet which is given to the mother. Zaid, it depends on when it was diagnosed and what is the prothrombin time, and it is continuously given till delivery. Right? No method of fetal monitoring has been shown to predict fetuses at risk of adverse perinatal outcome, and nothing reduces the risk. But like we already decided that continuous fetal electronic monitoring is offered to the patients. So these patients, antenatal patients, when they come in labor, they are under consultant-led care. They have to deliver in a hospital, and continuous electronic fetal monitoring is given to them. There is no other antenatal monitoring that is going to predict an adverse pregnancy outcome. Role of elective delivery. Patients are usually offered induction of labor after 37 weeks of gestation. And this is done after careful counseling about increased perinatal morbidity and mortality because of preterm delivery. There could be maternal morbidity because induction, which could lead to cesarean section, etc. And we need to counsel them that after 37 weeks of gestation, there's an increased chances of the patient having a stillbirth, and we do not have any method to predict it. So induction of labor is offered at 37 weeks of gestation. The mode of delivery is usually individualized depending on that particular patient, but induction of labor is offered at 37 weeks of gestation. I hope this is clear, and we'll move on to the next one. Now coming to the follow-up, again an important question. So we need to follow up these patients, and we need to make sure that the LFTs return to normal. The LFT investigations are deferred for the first 10 days because the levels usually raise after delivery. But LFTs are done at 6 weeks after delivery, and the appointment is usually at 8 weeks. So these are all important questions. LFTs are deferred till 10 days, followed up at 6 weeks, repeated at 6 weeks, and followed up at the 8-week appointment. Ma'am, if obstetric cholestasis is diagnosed with abnormal LFT, we do weekly. Yes, we do weekly, correct, Saiba? If obstetric cholestasis is diagnosed with abnormal LFT, we do weekly LFT antenatally till delivery. And if it is not diagnosed, if the patient only has itching and the investigations are normal, we would repeat every 1 to 2 weekly. All right. LFT postnatally, after 6 weeks, we have to defer for the first 10 days. Okay, Geeta? Defer for the first 10 days, repeat at 6 weeks.
And here I want to add one thing, Pradnya, because this question is very much confusing in terms of questions, SPAs and EMQs, because everyone says that 10 days, 10 days, 10 days.
10
Look,
days.
my dear all, because maternal biochemistry takes time to revert back to normal after pregnancy. Okay, guideline has clearly said if at all you have to do the LFTs right after delivery, so don't do it in initial 10 days. Do it by after 10 days. Okay, but for almost all medical disorders, you have to have a 6 to 8 weeks postnatal checkup. Okay, this is also a rule for almost all medical disorder. So likewise, when in a question it is being asked that when you have to repeat LFTs, so you have to choose 6 weeks, unless it is given that how early you can do LFTs after obstetric cholestasis delivery, then you can choose 10 days. Okay, I know this is a big dilemma, and Geeta is 100% right in this thing. Okay, so I just want to clear this thing out, that if the question is that how early you can do LFT, choose 10 days. And if the question is when you have to repeat LFT after OC delivery, then you will choose 6 weeks. Okay.
Thank you, Dr. Zaib. This is a constant confusion for everyone.
Yes.
Everybody is confused between 10 days, and I don't know why everybody keeps thinking it is 10 days.
Yes.
Actually,
I think I will turn 50 years, but still I will be answering this question. No problem, no problem.
So defer it for
Okay.
the first 10 days and repeat it at 6 weeks, follow up at 8 weeks. Yes. So let's move on. Yeah. So if the liver transaminases or serum bile acids remain elevated at the postnatal check, we need to look for alternate causes of why this is happening. So there could be a lot of reasons why the investigations or the blood tests are still abnormal. So these are the differential diagnoses that we need to keep in mind if the reports are still higher after delivery. There could be viral hepatitis, there could be primary biliary cirrhosis, primary sclerosing cholangitis, or autoimmune hepatitis. These are the conditions in which we will be doing anti-nuclear antibodies or the autosomal autoimmune tests to rule these conditions out. There could be biliary obstruction, there could be veno-occlusive diseases, and the investigations are mentioned on the right side. Right. So during the follow-up, we need to tell the patient that there are no long-term sequelae for the mother or the baby. So she can be reassured about that having obstetric cholestasis now is not going to lead her to having some problems later on in life, or for the baby for that matter. But during her next pregnancy, there's a high recurrence rate, as high as 45 to 90%. Again, this has been asked multiple times and a very important incidence. It is also, she also has to be advised that she is to avoid estrogen containing methods because they can lead to similar symptoms in her. So all estrogen containing methods are to be avoided in these patients. She has to be advised that if she has a sister or somebody else in the family who's going to have a baby, there could be an increased incidence of obstetric cholestasis in them as well. Well, this was a very short guideline. I hope I cleared it, and as it was too late, so I brushed through it. But we do have some questions. I need some volunteers who can take up these questions. Do I have
It was a
some
quick and crisp revision. Very
Yes.
good. Thank you.
So basically, how you need to make notes is they have to be very specific to the kind of questions that are asked in the exams. You don't really need to sit and write down the entire GTJ because that's going to take ages. Okay, Noshin Man, right? So, Anusuya also raised her hand. Whoever wants to take the question can unmute themselves, and then I'll go to the question screen. Anusuya,
Yes,
you want to? Pallavi also is here. Hi, Pallavi. Well, this is the first question. Who wants to take it?
I can take it.
Sure, go ahead.
35-year-old paravan, 34 weeks present.
Please read it aloud so others can also hear.
A 5-year-old paravan, 34 weeks pregnant, present to the assessment unit complaining of pruritus, especially palm and sore. She reports good development. Her pregnancy has been uneventful so far. She also gives history of induction of labor at 38 weeks for obstetric cholestasis in her first pregnancy. Inspection of the skin shows scratch marks, but no rash. Symphysis fundal height is 36 centimeters and CTG is normal. Her LFT shows an elevated LMI, transaminase, and bile acid. You suspect obstetric cholestasis. How would you counsel her regarding obstetric cholestasis? A is wrong because recurrence rate is up to 90%.
Yeah.
PPH, there is no figure for PPH. There is a risk of PPH if she has got severe more than 100 micromole per liter. Then or prothrombin is prolonged, then she will be at risk of PPH, but there is no specific figure. Risk of
There is a specific figure I had mentioned in vaginal delivery and cesarean section, 2.5 and 6.1. Right?
Oh, I'm sorry.
Yeah, but you're right. PPH 35 is wrong. Yeah, next option.
Spontaneous prematurity is around 35%. Risk of spontaneous prematurity is there, but it's not 35%. Ursodeoxycholic acid improves itching and reduces the incidence of abnormal. That is wrong because there is no effect on the Dopplers. Early term delivery is not associated with increased incidence of cesarean section. That is wrong because early term delivery can be associated with increased incidence. So I think everything is wrong.
That's not possible, right? There has to be a single best answer.
Okay. So recurrence.
Early term disease.
So is it recurrence between 20 to 90%? So 35% falls between that.
So does anybody else have an answer? You can tell me in the chat. Everything seems wrong.
I will go with A because it falls between that bracket of recurrence?
No, the bracket is 45 to 90%.
So it will be C, spontaneous prematurity.
This PPH rate is very high as compared to the
Yeah.
incidence.
It's maybe E. Early term delivery is associated with increased incidence.
It is E.
Yeah,
because
it's E.
early term delivery overall is associated with maybe increased incidence of cesarean section because of induction, etc. But the guideline specifically tells that there is no increased incidence of cesarean section because of early term delivery in obstetric cholestasis. Right? So overall, if you think according to clinical, like what Dr. Hasan said, don't mix your clinical practice with the guideline. The guideline very specifically tells that early term delivery is not associated with an increased incidence of cesarean section. So this is the correct answer. Yes, so the answer is E, Umaira. I really want to comment on the way you solved the question. Ruling out things is a very good thing to do, especially when you're stuck and when you're not sure what the answer is. Sometimes you're very sure that this is the wrong answer, right? Like how you were very sure that A, B, C, D is wrong. And you're usually left with the right one. So this is a really good way of solving questions and amazing. Great. So I have another question. Who's going to take that? Okay, I'll go to the next slide later. Yeah. Who's going to take it?
Yes, ma'am.
Yes, ma'am.
Who is it? What's your name, please?
Yes, ma'am. Aisha.
Aisha, please go ahead. I'll go to the next slide. Yes.
Which one of the statements is true about counseling women with IHCP? Risk of recurrence in subsequent pregnancy is about 90%. Estrogen containing oral contraceptives should be avoided. Once diagnosed, liver function test should be monitored weekly. Hormonal replacement therapy should not be omitted. First is correct, and estrogen containing it is also correct. Once diagnosed, C is also correct. Hormonal. I'm not sure about D. Hormonal replacement therapy should not be omitted because estrogen will be there also.
Yes, but when is hormone replacement therapy given?
I mean,
After menopause, right?
yeah, correct. Correct.
Yeah.
So
So
all
what do you
are
think
true.
is the answer? Yes. Correct.
Yes, all are. Yes.
All are true.
Thank you.
Perfect. Well done.
Thank you.
All are.
Right. So now this is EMQ. So these are a little difficult. Who wants to have a go?
Wow, EMQ.
Ma'am, I'll try.
Sure, go ahead. So these are the options. I'll go to the first question. It's on the next page. Right?
Okay, ma'am.
Yeah, this is the first question.
Okay.
Please go through
A
this well.
Okay, for each description below, choose the single most appropriate answer from the above list of options. Each option may be used once, more than once, or not at all. A 30-year-old woman in her first pregnancy presents at 30 weeks gestation with severe itching involving the palms of her hands and soles of her feet. Her LFTs show normal bilirubin, a mild elevation of serum transaminases, and an elevated alkaline phosphatase level. An ultrasound demonstrates normal fetal growth. So normal bilirubin, mild elevation of serum transaminases. Okay.
These are your options.
Okay, ma'am. Induction, elective cesarean, no. And ma'am, request serum bile acids.
Very well done. Amazing. Yes, that is the right answer.
Okay. So, ma'am, if someone else wants to try the next.
Yes. Is somebody else who's willing to try next, or you can go ahead? Fiba, right? Can you tell me your name?
Fiba, yeah.
Fiba. Yeah, that's
Fiba,
right.
Fiba.
Fiba. Oh, okay, great.
Thank you, ma'am. Yeah. Second question, a 28-year-old woman in her first pregnancy is admitted in labor at 37 weeks gestation. She has a 5-week history of generalized itching, but on further questioning, this is predominantly on the soles of her feet and palms of her hands. LFT shows an elevated alkaline phosphatase, a bilirubin of 20 milligram per deciliter, and aspartate aminotransferase of 100 international units, and ALT of 110 in IU. On examination, she is having 3 contractions every 10 minutes. Vaginal examination reveals that the cervix is 5 cm dilated and there is meconium stain like so she's having 3 contractions, 5 cm dilated, meconium, AST, ALT elevated. Okay, ma'am. So maybe M, continuous CTG monitoring, ma'am.
Yes, correct. That's great.
Okay.
You're already prepared. So somebody else wants to take next 2 questions? Do we have any other volunteer?
If there's nobody, then I'm happy to take.
Sure, you can go ahead. Who is it?
Nosheen. Good to
Nausheen.
hear from you, Nosheen. How are you doing?
Thank you.
That's great. That's great.
A 10-year-old woman in her first pregnancy attends day assessment unit at 32 weeks of gestation with a history of severe itching and abdominal pain. On abdominal examination, the fetal presentation is cephalic and uterus is noted to be contracting irregularly. Vaginal examination demonstrates that the cervix is 2 centimeters. Her LFT results are as follows. Aspartate is 56, ALT is 60, alkaline phosphatase is raised, bilirubin is 10. An ultrasound scan demonstrates normal fetal movement and liquor volume. Her autoimmune and viral screenings are negative, but the bile acids are elevated. So she's 27 years old. Oh, can I see the?
Okay, go through it, yeah. 27 years old, yes.
Weeks pregnant. She has got irregular contraction. She is 2 centimeters, so she's in latent phase. Her bile acids are raised, so her autoimmune is negative, bile acids are elevated. So yes, I can see the option. So induction, there's no point in induction because she's already in latent phase. Chlorpheniramine itching is there, but that is not an immediate concern. Elective section, not an option. Induction, she's already in latent phase. Steroids, 37 weeks, we don't have to. Oh, you've given an answer. Request
No,
serum.
that's for the first question, and this is for the second one. Now is yours.
Bile acid is already raised. S-adenosine methionine we don't give. Betamethasone not needed. Umbilical Doppler not needed. It's written it's normal. Growth scan we don't have to. She already had it. Emergency section continuous monitoring. Vitamin K also not needed. So emergency section or continuous monitoring. I will.
Nausheen, how many weeks was she?
She was 37 weeks. So
are you sure?
Yeah, can I have a look?
32 weeks. At 32 weeks.
Oh, she's 32 weeks.
So what do you think would be the answer?
So answer should be O.
O?
So first she's in latent phase, she's preterm, so she needs steroid for preterm delivery. So she needs admission, steroid.
Yes, so she needs betamethasone. You're right, steroids, because she's going to be delivered now.
Yeah, but I made a silly mistake. I forgot.
Yes. So it's very important to read questions. Absolutely very, very important, and to remember. So what you can do is just, they give you a paper and a pen. You can just jot down important points so you don't forget while going back at the options. So write down 27, whatever, 32 weeks of gestation, latent labor, obstetric cholestasis. So if you have these 3 things in mind, you know, she's 32 weeks in latent labor. Now we need to give her steroids. Right? Nothing else is going to work at this stage. Okay, go ahead with the next question and you get this right.
30-year-old primate woman presents at 34 weeks of gestation with severe itching involving palms of her hand and sole of her feet. LFT shows AST and ALT 90 and 100 respectively. Bile acids are noted to be elevated. A viral screen and autoimmune screen are negative with normal coagulation. Fetus is appropriately grown for gestation. So she's 34 with severe itching She has got a diagnosis of OC. Her baby is fine. So we have to give her treatment, which is chlorpheniramine or urso. So chlorpheniramine for symptomatic. So if I have to choose between two, I
We
don't
will
know.
give option O for oxycolic acid.
So chlorpheniramine is for itching, and ursodeoxycholic acid is going to help with her pruritus and improve her LFTs. So which would you give?
So I would give urso because it will give me two benefits.
Correct. So this is the answer. Yes. Dr. Zaib is also answering.
Yes, yes. I'm also enjoying these questions.
Thank you.
Great. So we do have a lot of fun on our groups as well. Right. So this is, I think we are at the end of the session. Thank you so much, guys, for participating. It was a great fun. And it is usually fun doing these sessions and solving questions together. I hope to see you all in the sessions. The references for these, the obstetric cholestasis were the GTG and the talk article. And on this note, I want to say a huge thank you for attending and for being a part of this. Dr. Zaib, if you want to say something.
Thank you so much, everyone, for being so attentive and lovely audience. And we really enjoyed today's session. So, if you guys have any query in terms of preparation, in terms of, the exam, you guys can always reach out to us. Okay. So we are on Telegram, we are on Facebook, we are almost everywhere. So you guys can, reach out to us. Okay. So not you have to take the courses. Okay. So we are here to help. I will repeat again, we do have our Telegram guide group, we do have our Facebook guide group, so we are always there to help you guys. Okay.
Absolutely.
So yes, so never think that we will always help you once you will take up a course or something. Of course, course is exclusively for those candidates who are going to be in course, of course. Okay. But yes, we are in the Telegram groups as well. So yes, Sir Hassan, I would like to hear your voice. The end note. I would like to end this session with your voice.
I'm laughing a lot because you said on Facebook, if not Facebook, Telegram, WhatsApp,
Yes.
blah blah blah. So I feel we are trapped.